Hi everyone, my name is Havlin. Thank you for joining Pre-Health Shadowing today, and we are so excited to have Dr. Mays here with us. We are going to start off with some intro slides. So I'm going to go ahead and share my screen, and then we'll get started. There we go. Thank you again, everyone, for joining us today. We are Pre-Health Shadowing. We are an international student-led nonprofit for medical advancement. So our entire team is really passionate about sharing about all of the health professions and hopefully getting folks interested more in the field or in some other professions that they didn't even know existed. So we're really excited to have you all here today. We do have closed captions available for all of our sessions. Our goal is always to make our sessions as accessible as possible to accommodate all students. And if you ever think we can do a better job at doing that, we do encourage you to email us at info@prehealthshadowing.com. Just in general, that's a great email to have. If you ever have any questions or want to get into contact with anybody on our team, you can send it there and we will get back to you as soon as we can. Also, it's great to save us as a contact. Keep us out of your spam. Make sure you stay up to date on all of our sessions. We do have a variety of social media platforms as well that we do update regularly. We have Instagram, TikTok, X, YouTube, Facebook. Special shout out to LinkedIn as well. If you're trying to expand your professional network, that's a great way to do it. Right. Starting off, we do want to know where you're all from. Like I said, we are an international organization, so we have folks coming from all over. So please feel free to drop it in the chat. We'd love to see where y'all are from. I am from the Los Angeles area, specifically Chino Hills. I see Toronto, Canada, Kentucky, Texas, New York, Mississippi, Puerto Rico, Arizona. All right, we got all coasts covered and the middle. That's so exciting to see y'all here. And we do know that the time zones are different everywhere. So for some folks, it's day, night. So we're really excited that you could all make the time to join. If you're interested in becoming a part of pre-health shadowing, you can register as a volunteer on our website. All of our positions are 100% remote. It's a great opportunity to get involved and to learn some new things, and also grow in your professional development skills. If you have any questions, like I said, feel free to send us an email and we'd love to connect with you. We also have some leadership opportunities. If you do have a couple more hours that you can commit to pre-health shadowing per week, we do have a 5 hour per week commitment for leadership team, but we have a variety of positions that are available, and we're also open to kind of expanding our position list. We have a full list available on our website, but if you see some gaps or some ways that you think pre-health shadowing could improve, please let us know, and we'd be happy to open up that role for you. If you are a high school student, we highly encourage you to join our high school training program. We offer leadership and healthcare education for pre-college learners. So if you are currently in high school and want to bring pre-health shadowing to your campus directly, this is a great way to do it. Our team will work with you to connect with pre-health shadowing, how to form events, and get everything together. So we're really excited for that opportunity for all of our pre-college learners. Our program is 100% free. We survive and thrive off of all of the donations from folks all over the world. And we are so happy that we are able to do so. So if you can donate, we really appreciate it. 50 cents, a dollar, whatever you can. It really does make a huge difference. Another thing you can do is donating your time. If you can't donate financially at this time, we completely understand it. And we would love to see you donate your time in one of our volunteer opportunities, as well as sharing our QR code and any of our links with your network. If you know anybody that's passionate about helping folks that are interested in health professions, this is a great way for them to do it. We will have our chat on throughout this session, so please type your questions in the chat. Make sure you don't forget them. And we will be noting them down. That way we can ask them formally to Dr. Mays during our Q&A. Dr. Mays is really excited to hear all of your questions, so make sure to keep typing them in the chat. And you will also have the opportunity to raise your hand and ask the question aloud towards our Q&A. Please make sure you're also taking good notes on everything that we're going over throughout this presentation, any new things that you learn or anything you want to look up later. It's always great to have the notes. Also, after the session, if you want to reflect on anything new that you learned, it's great to look back for those notes, as well as for our post-session assessment. Those notes will probably be really helpful there too. And we'll go over that in detail at the end of this session. Lastly, we do ask if you can, if you are in the space where you can turn your cameras on, we really, really would appreciate it. It's nice to see everyone's smiling faces. We get some spirit fingers going. It's really fun. It's a good time. Please turn your camera on if you're able. All right, and that's it for me, and I'll toss it over to Dr. Mays. Thank you so much for being here.
Thank you so much. And hi, everybody. I'm Linda Mays, and I am at the Yale Child Study Center in New Haven, Connecticut. It's a part of the Yale School of Medicine. And I thought I would begin just by a little bit about who I am as a physician and how I got into medicine, but I really want most to hear from you. Medicine is such a wonderful field to be in, but I want to hear your questions and how I can be of help. So I decided to go into medicine a long way back, actually, when I was a young child, and for a host of reasons, which I'd be glad to talk about with you, some of which I've come to understand only later. But I got to medical school with every intent of being actually an internist. I also was interested in neurosurgery, but I was pretty sure I was going to do internal medicine because I really, really like diagnoses and I like complex things. But at the medical school I went to, which was at Vanderbilt in Tennessee, we had the system of having advisors, and my advisor suggested, why didn't I also just sample some other fields, including pediatrics? And I turned out to absolutely love pediatrics. To my actual surprise, to be quite frank, what I really, really loved about pediatrics was you can make the chance to make a difference actually for somebody's whole life. The things we do with young children, with infants and young children, can potentially impact the rest of their lives. I also really loved development and child development, how children emerge, how quickly they learn. I am a bit especially interested in physiology and early childhood infancy physiology is right there in front of you. And I'll tell you a little bit more about my pediatric residency. But so I decided to become a pediatrician. But I was always and continue to be, because I do work in an academic medical system. I wanted to do research. I wanted to be in the academy. So I did a pediatric fellowship and then decided to do a fellowship in neonatology, working in the intensive care unit with very preterm infants. And I decided to do that actually because of my interest in intensive care and physiology. And I loved neonatology. I still love neonatology, but I am not practicing in neonatology, and I'll tell you why. What I loved about neonatology was, again, this idea of what we do, how we understand how the body works, can make a difference for their children's whole lives. But what really got me interested in the neonatal intensive care unit is that we would see the children um, after they left the nursery. We would see them when they were 3 years old, when they were 5, when they were 16, when they were 18. And what I was so interested in and I didn't know anything about what I know now about child development, all of that. But I was so interested in that here would come these athletic, healthy young children, adolescents, and their parents would still be worried about could the lung disease of prematurity come back? Were they able? Their parents were still thinking of them as these very fragile infants. And I wanted to learn more about how over time those kinds of beliefs, those kinds of worries persisted. And so my whole career shifted. and I decided to do a fellowship in doing longitudinal research, how you follow families. Now, you might think as a healthcare professional, that's what we do. We work with our patients over time. But we don't really think about it as longitudinal research. And so that's what I decided to do. I wanted to learn how to do that, and I wanted to understand how early experiences could be so persistent and shape how parents thought about their children, how their children thought about themselves. So I came to Yale to do what at that time was called a Robert Wood Johnson General Academic Pediatric Fellowship. How do you do research in a pediatric setting? And I can tell you some about my early research, but what happened, just to finish the arc of where I am now, is I really got interested in children's mental health, in development and mental health, and how development unfolds over time, what shapes it over time. And so I was just really very fortunate to join a department, the department I'm in now, called the Yale Child Study Center, which is a department in the School of Medicine at Yale that's been around for now over 100 years. Started with some very prominent pediatrician psychologists studying children's development. And I joined that department as a pediatrician. And what I do now, and I'll be glad to tell you about my research, but what I do now is while I am a pediatrician at heart, I work in the mental health field. I work with children who are struggling with depression or anxiety or have had traumatic experiences. I work in that field, and I'm not a child psychiatrist, but I am a mental health professional. And while this may sound like a little bit of a sidestep, I can explain that one too if you ask me questions. I'm also trained as a child and adult psychoanalyst. So that's my mental health background. My research has always been longitudinal. I've always looked at experiences early in development and how they express across the lifespan. And the central research that I've done is looking at how prenatal drug exposure, cocaine, tobacco, marijuana, how exposures prenatally express across the lifespan, and especially on children's cognitive and emotional development, and how prenatal experiences such as drug exposure may increase the risk for other problems in childhood, in adolescence, or even into adulthood. And another aspect of my research is also looking at how addiction impacts adult transition to becoming parents. We know a lot about becoming a parent, but one of the things that is of the last really 10 years is how the brain changes when adults assume the care for another. And that's a part of my work, is how addiction impacts that. So I would say, again, I'm a pediatrician working in the mental health interface. My research is very psychological. I do use methods such as brain imaging, but I think very much about the emergence of mind and how children learn all of those kinds of developmental psychological questions. And my current responsibilities as a physician is I actually am the department chair. So I have the gift now of being able to help others find their developmental path and help this department that I actually care a lot about. And I care a lot about the history of the Child Study Center. So I've said a lot, and I may have actually used terms that I need to explain, so I would need to hear from you. Um, and what I really most want to do tonight with you, and for some of you it's afternoon, for me it's tonight. What I really would like to do is to hear what kinds of questions you have. I think I would just end with what I'm saying to say that I feel very honored to be in the healthcare profession. To me, I feel it is actually a gift to be in this profession because, especially as a pediatrician, but I would say any other time, we have a chance to impact positively people's lives. And many, many times, especially families coming to me or my colleagues, they're coming at times that are of great challenge for them. And that when people bring their trust to us as physicians, asking to be for help, I think that is both humbling and a gift to be able to do that if we can. So I'd be also delighted to talk about the changes I think in the healthcare profession, but most importantly, for me, my identity is as a caring or healing professional. And for all the research and all the medical school, this or that, I think that is at the core of being a healthcare professional is to be a healer. So let me stop and see what questions you would have and how I can be helpful.
Thank you, Dr. Mays, for sharing that so far. I see a question in the chat. Lauren is asking, what are some valuable words of advice or tips you can provide to pre-med undergrad students or college students aspiring to work in medicine?
Yeah, so that's a great question. And I would say a couple of things. One is probably three things I would say. So one is, and I think this is likely not the trend most of you are anticipating, but for me, I went straight from college into medical school. I mean, I was fortunate to have that opportunity, but that's what I did. I would never do that again. And it's not that I'm not delighted to be a physician and any of that, but I think it's really important between college and medical school to have some kind of work experience in between. Um, Partly to see is this profession, this healthcare profession broadly writ, where you want to be, but also partly to give yourself a broader experience and to give you a break between college and medical school. Because I see the next question was, what's the hardest thing about medical school or that I experienced? So that's one piece. I think the other, another is to talk to as many people, talk to people who are in the healthcare profession, physicians, nurses, physicians' assistants, physical therapists, people that are in the healthcare profession. Talk to them, ask them about why did they do it? What did they find most interesting? And by the way, you may be surprised that I would also add people who are in the business of healthcare, healthcare economists, people who are investing in healthcare, because that's one of the changes in medicine right now is that it is also a business. And it's important that we think about that. And then I suppose the third thing that I would say may sound a bit idealistic, but I'll always be grateful to that Vanderbilt advisor that said, why don't you just sample some other things? Because I was completely blinders on, headed exactly where I thought I wanted to be with very little sampling. And I was really grateful that he said, sample, try some other things. And so you may already know that you want to be an orthopedic surgeon. That's great. Okay, good. Try sample some other things. And you may still be an orthopedic surgeon, but really it's important to medicine is a vast, vast field. And it's really important. So those would be the three things that I would offer.
Speaking of that advisor at Vanderbilt, we did have someone ask, what was your experience like at Vanderbilt?
Oh, I loved Vanderbilt. And I can say a little bit more that I loved Vanderbilt. I did love Vanderbilt. You may or may not can hear in my accent that I am, or at least a long time ago, I was from the South. I was from Tennessee. And I really enjoyed living in Nashville. But what I liked about Vanderbilt, was we got a deep, I got a great medical education, but I also had a lot of experience or a lot of ways to sample research, to actually sample what it was like to be an academician as well as a clinician. And I liked the variety of experiences that Vanderbilt offered. At that time, Vanderbilt was working on also outreach to rural health areas, which they're doing more of now. But so if one wanted, you could have that experience as well. So it's a school where I liked that you could become clinically immersed, or you could also experiment with this research clinical interface. And I happen to have the fortune to have I made an observation in the neonatal intensive care nursery when I was a fourth year medical student about a possible drug interaction and had a mentor in pediatrics who offered to let me model that in an animal model in his lab. And he taught me an enormous amount about doing research in a clinical setting. I didn't end up going into animal, well, I work with humans. I didn't go into basic science research, but I learned a huge amount from him. And I'll always also be very appreciative to him. One of the things I learned from him was that in the research world, that research motive, there will always be patients who need to be seen when you're a physician. There will always be patients. The research world, though, comes very much from an internal motivation to answer that question, pursue that finding, and that it's an important balance between patient care and research. Um, so those are the things I liked about Vanderbilt.
Ramisa asks, what was the hardest part about medical school?
For me, the hardest part about medical school was really, well, I came from a liberal arts education, and I came from a college where, well, what we did was we discussed, we talked. We didn't really learn facts. We learned how to talk. We learned how to think about issues, how to engage in discussion. So I actually, and I hope things have changed a bit now. In fact, I know they have at Yale. I know they have in medical education. But in my first year of medical education, there was an awful lot of true, false, true, false, answer this question out of a choice of four. And I found myself always wanting to, at least in the first few months, debate, well, it could be true, but here are the conditions where it wouldn't be true. And so to go from that kind of liberal arts approach to a more, here is a ton of information to learn and you need to learn it, I found that transition hard. Um, I managed it. And now I don't think I'd find it as hard, but that was a bit of a culture shock to me. And the volume, just the sheer volume of information to learn was hard. Once you get into the swing of it, and once for me, it all came together when we had the first opportunity to talk to patients, to be on the clinical ward, to actually be engaged, or at least a part of the clinical team. It just all came together. And all of that, reading page after page, fact after fact, all of that kind of took a back seat because then I could see why we were doing all of that. And that it was going to be a lifelong of learning. So that to me was the hardest part.
Juan asks, in routine pediatric practice, what are some early physiological signs that suggest emerging regulatory dysfunction before behavioral symptoms become obvious?
Oh, that's a great question. There's a lot of them. Some are quite subtle. Um, and um, Let me take one step back. One of the things that another of the many things I enjoy about pediatrics is that it's a field that can be quite subtle. You really have, by and large, children are healthy, unless you're in particularly high risk environments. But by and large, in a pediatric practice, children are healthy. So pediatricians need to be exquisite observers. They need to be very tuned in to that slight change or that slight difference, or listening to a parent's concern. And it's one of the challenges of pediatrics is not to get habituated, if you will, to all the normalcy around you, but to always be listening. So some of the signs, it depends on what age you're talking about, but children who are developing right along and suddenly start to lose skills or suddenly stop developing, their language stops or they stop talking. Children who have what we might call regulatory issues, that is, their sleep has been going along well and then it changes, or they stop eating or their eating patterns change, or they become more irritable, or they were once a happy child and all of a sudden they seem more subdued and more withdrawn. Those are the things that pediatricians should be alert to pay attention to. Um, they may or may not indicate a serious problem on the horizon, but they do indicate that something's happening that for that child is trying to both physiologically and psychologically adjust to. It's not actually uncommon when children, for example, are um, let's see, what would be an example? Well, children may have mastered a particular skill. Um, so here's one. Here's one that's actually relatively common. So a child may actually be toilet trained, which is usually somewhere around a year. But they're starting to work on another set of skills, another set of uh, skills. And they'll briefly lose that toilet training capacity as they're working on something else. Now, working on it makes it sound so conscious as other skills are coming online. So that kind of ebb and flow of development, gain with a little bit of gain in this way, staying stagnant in this way, pediatricians need to learn how to pay attention to that. Some of it can be quite normal. Uh, Children who are just, for example, learning to walk independently may not sleep through the night because there's a lot of brain development, if you will, happening. Those are the things that pediatricians need to pay attention to. I don't mean to say that we don't have structured ways of doing it. We have developmental assessments. We have developmental milestone kind checklist. We have all those things, but you need to really, really listen to when a parent says something like, "He's just not himself these days. I'm not sure what's going on, but he's just not himself." A busy pediatrician might miss that. And those are the kinds of things you want to listen to.
Additionally, how early can pediatricians reliably identify infants at high risk for stress response dysregulation?
Our crystal ball is a very cloudy one. So when you're asking those kinds of questions, it's better to think about risk. And what I mean by that is think about the various factors that might increase the likelihood that a child will develop some or have some developmental questions or problems. You're not really saying, that at time A is definitely going to be a problem at time B, because everything we think about is in terms of risk. Just like an adult, we know now that an adult who smokes is at greater risk for developing lung cancer. It doesn't mean that every adult who smokes is going to have lung cancer. They aren't. but smoking increases your risk. So thinking about the variety of things that increase child risk for problems. Prematurity is one of those. Infants born prematurely are at greater risk for learning challenges in school. That can be moderated tremendously by the caring environment that they are in. Uh, Prematurity coupled with more environmental deprivation. By that I mean all the things that might come along with poverty or less adequate nutrition that will increase risk. Uh, Parental mental health, parental depression is a risk factor for potential later developmental issues. So those are all the things. Infants who have prolonged hospitalizations uh, without the um, without the usual kind of stimulation that we hope for all infants, that's a risk. Uh, all of these risks, children can do remarkably well and not have any problems. That's why I mean our crystal ball is cloudy, but we know that basically what we fundamentally know is that children develop better in with caring relationships with parents or adults around them who are able to provide for them psychologically and physiologically. That just fundamentally they do better with caring, responsive relationships. And even if they've had really rough starts in life, they can do quite well being in a very caring family.
Please correct me if I'm wrong. Veronique, I see you have your hand raised. Go ahead.
Hi, Veronique.
Hi. Um, Thank you for everything you've spoken. I find it
Sure.
so interesting. I have a two-part question.
Sure.
I wanted to know, why did you decide to specialize in psychoanalysis rather than psychiatry? And if you believe that the psychoanalysis training was more beneficial for your, not only your clinical research, but your practice rather than psychiatric training.
Mm. Okay. Delighted to talk about that. So I decided on psychoanalysis. It really wasn't a choice for me between psychoanalysis and psychiatric training. I was already a board certified pediatrician, and I didn't, honestly, I didn't actually really want to go the direction of doing another residency in psychiatry, but that really wasn't why I decided on psychoanalysis. I decided on psychoanalysis for two reasons. One is that in the department that I am currently still in, and I was in at the time, there was very much a tradition, and still is, of understanding of multiple theories of development, but one of them was understanding what we call children's inner worlds, um, how their mind emerges, how we think about not just physical development, but how we think about mental development. And there's numbers of ways of coming at that. Cognitive psychology is one, social psychology, but psychoanalysis offers one of another approach. And our department had a long history, actually, of what we might call applied psychoanalysis. In fact, Anna Freud, Sigmund Freud's daughter, was a collaborator with early faculty in our department, looking at how she was very interested in how adverse experiences, such as trauma, impact children across the lifespan. So I decided to learn more about, I wanted to learn more about how to think about children's internal worlds, how to think about how they're working out their own feelings and their own identity, and how I could help with them with that. And that's why I decided to do it uh, from a professional point of view. And also, it was a language that was being used in my department. And I wanted to be conversant in it. I wanted to be able to talk. I wanted to be able not only to be conversant, but to be able to think about multiple theories of development. From me, it's actually been personally, both personally, very, very helpful. But also theoretically, I think it shifted being able to think not only about observable stages of children's development, but also thinking about how their own minds and their own sense of self is emerging over time. That has changed my research questions. I did and still do a longitudinal study, as I told you earlier, about cocaine exposure and long-term development. That study has multiple levels of analysis. It has neuroimaging, looking at brain effect, but we also go all the way to looking at how children's sense of self has emerges and how we measure that. We think about their internal experience and we measure that. We look at their play and how they express themselves through the language of play. So that's what psychoanalysis is to me. It's another way, not a different, it's another way of thinking about development in children's minds. I don't, right now, because of being department chair, I don't actually use that approach clinically. I don't see children in analysis, but it still informs a great deal of my thinking.
I'm sorry to add something else, but I just wanted I had the curiosity because you said that you had training in child and adult psychoanalysis. Do you think that
Yes.
it helped you not directly like as a patient, but with the parents of the children?
For child psychoanalysis or the adult?
The adult part.
Oh, so the adult psychoanalysis part is I am trained to work with adults in psychoanalysis if they are seeking psychoanalytic treatment or seeking some kind of mental health treatment. I am trained to do that, and I have done that. I am primarily a child professional, so I'm not doing work with adults now, but I have done so, and that is part of the training. Does that help?
Yeah, I was just wondering if you think that with the parents of the children who like you treat, if
Yeah.
you think that the psychoanalysis training has helped you just in your practice, not necessarily treating adults, but just sort of like dealing with that child-adult
Oh yeah.
relationship.
No, I think so. Uh, I think um, I think primarily how it's helped me is I'd be very curious. I think I don't want to turn the question back to you, but sometimes I realize that people have kind of different thoughts about what psychoanalysis is and what it means. For me, it is a very open way of thinking, and so it has helped me in my work with parents because it's helped me in a way be, I would say, less judgmental. And what I mean by that is oftentimes when you're a professional working with children and you see a child in distress or you see a child that they could have a better environment. They could be cared for better. Or you see a child that's brought to you, and let me just be even more concrete. They're not gaining weight, and they're kind of it looks like that they just aren't getting the care they need. So often as a child professional, what happens is that we, in a way appropriately, get really, really frustrated with the adults around them. Shouldn't adults care for children in ways that allow them to thrive? And I think my training and being in the department I'm in, I've learned to think much more about in a less kind of should or should not, but more in a way of where are these adults coming from? What's been their past experience as children? What do they bring to their role as parents? How do they think about being a parent? How can we as child professionals also help them be the parent they want to be? And so thinking not so much as good, bad, should not, but beginning to understand the parents and their own development Adults who become parents are developing themselves. Their brain is changing and they are also continuing to develop. So I think the psychoanalytic perspective has helped me to be more curious, more accepting of development as a lifelong process.
Thank you so much.
You sure?
We have a few folks asking about your journey to medicine, more specifically, how you chose between the many specialties and how much you knew about pediatrics before going into medical school.
I'm not laughing at the question. It's actually a very good question. It's just so um, if you had asked me a while back, why did I choose medicine? I would have said, and this would still be a partially accurate answer. I would have said because I really like science, which I do. And I really like using science to solve complicated problems and help people. That would have been a right answer, but it wouldn't have been the full answer. And I think that I actually chose medicine because as a child, I had both a very good pediatrician whom I liked a lot, but I also had a very serious life-threatening illness. I had meningitis as a child, and my pediatrician was there by my side, and this was in the rural setting, so she was a rural pediatrician. So she didn't see many children with meningitis, and she saved my life. Um, and and so I think on some level, um, well, it is true that science and using science is still very important to me. On some level, I chose to be in medicine as a paying it back, paying it both back and forward, and a kind of, not kind of, an admiration for her. I recently had the experience of just completely out of the blue meeting her, and she has passed away a number of years ago, but meeting her daughter-in-law and discovering that her daughter-in-law had meningitis, amazingly from the same small town, and that before she became my pediatrician's daughter-in-law, she was my pediatrician's child patient. And of course, as a child, had no idea that she would become my pediatrician's daughter-in-law. But and just the devotion that she, not only as married now to my pediatrician's son, but the devotion, the care, and she spoke so much about how so many people talked about, well, I can use her name, Dr. Cameron, and how she had been such a devoted physician, which is true. So I think on a personal level, that was the other reason for me about medicine. However, I did not think about pediatrics till my advisor at Vanderbilt. I thought about internal medicine, and the reason I liked internal medicine because I'd read a lot of physician stories and those kinds of, complex diagnostic presentations and the physician listening carefully and solving the problem. And I wanted to be that internist. I wanted to be that solving the problem internist. I still like internal medicine. I like pediatrics better. But that's so I chose pediatrics actually really because my Vanderbilt advisor exposed me to it and and exposed me to it pretty early in my first year of medical school.
And when you were rotating in pediatrics, what kind of spoke to you about that experience that maybe solidified for you that this was your chosen field?
I think a little bit like what I said earlier, that first off, well, certainly inpatient or hospital-based pediatrics you see a lot of children are by and large healthy, but when they get sick, they can get really sick really fast. So I used a lot of my knowledge of what spoke to me was understanding physiology and understanding it at a level where you could really, really act on it quickly, if you will. I really enjoyed intensive care pediatrics, not just the nursery, but the intensive care unit. I enjoyed the fact that children get sick really quick, but they also recover really quick. And you can, if all has gone well, and that you can make really remarkably impactful changes, not just for them, but for their family that will last a lifetime. And I also enjoyed children just change quicker than adults. And I think, and I liked seeing that. And I think the other thing that it's probably not incredibly complimentary to adults, but I liked the fact that you could get some healthy behaviors going with kids, and that it was a lot harder to get an adult to stop smoking. But it might be a little easier to get a child out there, on the sports field, exercising and running and doing that. That you could change health understanding early, where it might be harder to do as an adult. And then also, while I still really do like internal medicine, uh, in adulthood, there was a lot of repairing that had to be done whereas in pediatrics, there's a lot of just making sure things are launched in the best way possible. I'm not trying to sell people on pediatrics. Really not, but it is a great profession.
Thank you for sharing that.
Sure.
Um, Kylie is asking, what advice would you give to someone struggling to decide between becoming an APN, a PA, or going to medical school?
Ah, great question. Because I think so often when we talk about medicine, we inadvertently have a hierarchy that, MD here and. I don't actually think that way. I think there are so many ways of being a healthcare professional, but so many ways of helping people. Um, and right now, well, not right now is the wrong way to put it. The medical profession now, um, physicians assistants and APRNs are absolutely essential frontline health professionals. Um, and if I would say one of the ways to think about that decision is partly to talk about people in each of those areas and to talk with them. If you have a chance to actually shadow with them, that's great. But to talk with them, find out what they do on a day-to-day basis. I talked to several of them, not just one. And also think what is it after you've gathered your information? What is it that you find most exciting about what they've told you? If it is being able to be right there every moment, taking care of patients all the time, um, and being the kind of front line, one of the physician assistants, ABRN, may actually be a, better than an MD, uh, better or different. Uh, I would shadow. That's what I would do. And see, and there's, like I say, there's so many ways to care for patients, so many ways. And I don't personally think that one way is better than another. Uh, you also need to look at the amount of time to get to being able to do that, the amount of time to being able to actually work in your chosen area. It's a long haul to be a physician, or to be completely in your chosen specialty. So think about it. That may or may not be a satisfactory answer, but ask me other questions and maybe I can fill that out a bit.
Yeah, please let us know if you need further elaboration on any of the questions that I'm asking.
Yeah, absolutely.
Somebody else asked, Scarlett asks, how did you go about preparing for your pediatric fellowship?
And the neonatology one or the residency?
They didn't specify, maybe a little bit of both.
Okay. Well, I so in medical school, typically whether it's pediatrics or whatever, you around your third year, you start to declare what specialty you might want, and you might take some additional electives in that area to assure yourself, or um, and then you typically go from graduating medical school into your internship residency. Now there are combined internship residencies now that, for example, there's one where you can do a combination of pediatrics, internal medicine, and so that's a little bit different. But you decide in medical school and then and then apply, if you will, to residency programs. My fellowship, I really liked neonatology because that was one of the rotations during pediatrics. So I applied to do an 2-year neonatology fellowship. And I happened to do all of that at Vanderbilt. You don't have to do it all at the same place. You can move around, which it's actually a good thing to do because you get exposed to different places. I'm not sure, though, that that answered the question.
Scarlett, let us know if that answered your question or if we'd like to elaborate. We
Sure.
also have a couple of students asking what kind of work experience would you generally recommend before someone goes to medical school? I know you spoke about the importance of work experience and kind of those
Yeah.
gap years. Specifically, we have a student named Stasia who is interested in going into psychiatry and
Mm,
a first gen pre-med student, so they don't have any idea how to navigate kind of the pipeline path when it comes to having a career in medicine.
sure. Well, so the work experience idea, or not idea, the work experience comment, I may be a little different from what you will hear. So basically, I would say that any work experience can be extremely valuable for medical school. And what I mean by that is that any work experience that gets you out with people, that gets you with a diverse group of people, and that you're having an experience where you have some challenges that you need to figure out. You need to test your skills. You need to see what are your strengths and your weaknesses. I would say any experience that allows you to learn a bit more about yourself. Again, your strengths, your weaknesses, the things you want to work on can be extremely valuable for medical school. You will hear a counterpoint of many, many, many people saying that those experiences should be in the healthcare profession. So if they're in the healthcare profession, you can be working in a hospital doing any number of things in a hospital that don't require a health professional degree. Now you can be working in the transport, moving patients from room to room. You can be working in medical records. You can be working at a front desk. You can be doing any number of things that put you in that environment. You can be until artificial intelligence has changed the way now we think about documentation. Prior to that, there were still a lot of jobs around being a medical scribe, where you were in a physician's office or a physician assistant or APRN following them and basically helping write their clinical note. That's a great way to do it. I personally would argue if you want to be in if you want to do a health related, even working for a healthcare business, uh, even working and learning what healthcare economics is about gets you into healthcare. it gets you into the language, it gets you into thinking about the field. Even working in a health policy kind of group, again, gets you thinking about the field. That's what I mean by any work experience is useful. I sometimes say it's how you tell the story. But what I mean by that is it's how you think about what skills, what learning, how you reflect on what those experiences have given you, and can you talk about them in that way?
Thank you for elaborating on that and sharing so many different examples for, I know folks have a variety of interests and access points, so it's good to hear. I see a question from Caitlin. Says that some people are stating that pediatrics is not worth it because the child birth rate is going down. In about years from now, do you think that pediatrics field will be much needed or worth it? Do you think there will be certain regions in the world that would be much better suited for pediatrics than the US?
It is so interesting that the birth rate is going down, um, and I think it's a question that certainly doesn't have, not the question itself, but the demographics of the declining birth rate does not have a single explanation. It's a complicated one. Um, and I think some of the reasons the birth rate's going down is people are worried about the future of the world. But yes, I do think do I think there's a role for pediatrics? Yes, I do. And I do think that there are places around the world, and then there are places in the United States where there still is a desperate need for pediatricians, and well, for physicians, period, but for pediatricians, rural healthcare. There are so many places in this country alone where children don't actually see a physician, let alone a pediatrician, in many, many rural settings, rural Appalachia being one. So I think there is still, even though there is a declining birth rate, I do think there's still a tremendous need for professionals who think about children and think about child development and think about how we can help children flourish in the best ways possible. There, obviously, in other countries, there is not a declining birth rate. And I think that as pediatricians, American trained pediatricians, we can actually serve a role by helping paraprofessionals in those countries learn some basic pediatric skills that they can take to families in need. That's the same thing would work well here too, because we'll never train probably enough. Even with a declining birth rate, we'll probably never train enough physicians, pediatricians for the real need. But I think you're right to ask about, I would just phrase the question to also ask about why is the birth rate going down? Uh, but I do think there is always a need. Now, there is an interesting phenomenon, though, happening in pediatrics. And that phenomenon is that there are many, many fewer individuals going into more general pediatrics, going into more what we call primary care pediatrics. And more individuals are going into subspecialties of pediatrics. But even there, those numbers are declining. And probably reflective of people's worry about the declining birth rate. I don't want to be too pessimistic, but there is also another issue or another reality, at least in American medicine, that child-related disciplines, child-related services are reimbursed less well compared to adult-related disciplines. So it's a little bit harder to be just, if you're out there in private practice, a little bit harder to be adequately remunerated if you're working in a child-related discipline. And that may be another reason for these fluctuations in the disciplines.
Thank you for that answer. Shifting gears a little bit back to your research,
Sure.
Badir, I hope I'm pronouncing that right, asks, can you elaborate on how the brain changes when people become parents? How does
Yeah.
this show in your fields when you're working with infants? Or have you done any research that focuses on that specifically?
Yeah, we have. So it's an interesting phenomenon. Most people wouldn't think that, well, I think there's several things. When we think about development, most people tend to think that well, if you manage to get to 18, development's all done. One of the things we actually know is that the brain continues to change throughout life, and it changes in a way to adapt to key developmental moments. So when we assume the care of a child, of an infant, and pregnancy is is obviously the predominant way that that happens. We actually have to completely adjust, if you will, our attentional economy. Uh, we have to start paying attention and be much more exquisitely sensitive to particular sensory cues. Uh, Parents, for example, are exquisitely better able to hear and distinguish the differences among infant cry types compared to non-parents. So there is a change in the attentional economy, is what I call it, or salience, that goes along with becoming a parent. And that alteration happens at the level of circuits that support reward processing in the brain and also support stress sensitivity. So why stress sensitivity? Well, if you think about it, it's actually a pretty difficult job to have a crying baby who can't really tell you that they're hungry, they're cold, they just can't tell you. And you got to figure it out. And that's pretty stressful. Uh, and at the same time, while you're stressed and worried and are you going to get it right, you've also got to be listening for the differences. You've got to be listening for those subtle differences and so you need to both have the reward part is it feels really good when you get it right. And so those are the circuits that get adapted. And they get adapted for um, paying a lot of attention to infant cues, and also for managing your own kind of stress and worry. We've done neuroimaging studies of parents as they've had a new infant, and we've looked at changes over the first months of life. And there are gray matter changes in the brain as parents learn about their baby. There are changes in these kind of center or areas of the brain that support reward, enhanced reward sensitivity to infant cues. So that's the kind of work that we've done. And then you start to ask what are the sources of individual differences in that transition. Because if there's individual differences, then you know that there's ways that you can intervene. You can make it, you can intervene. And there are individual differences brought about by parity, that is the number of children that someone's had, by age, by addiction, that is someone who is addicted to drugs. There will be individual differences and changes in these circuits as individuals become parents. So that's the kind of work we've done, and that's a very brief summary, but I hope it helps.
Another question in the chat from Juan. In early infancy, which physiological markers do you consider most clinically meaningful for identifying dysregulation, cortisol reactivity, heart rate variability, sleep architecture, feeding patterns, and how should pediatricians integrate those signals into routine care?
Good question. I think most of those signals, say for sleep regulation, perhaps, um, are probably more research tools. The sleep part, pediatricians definitely pay attention to. Um, Maybe feeding patterns, they certainly pay attention to. I would say, as a researcher, I would say all of those are things that we look at because they all look at regulatory patterns or capacity for what we call homeostasis, that is staying in a kind of physiologic rhythm. All of those we pay attention to as a researcher or a pediatrician. The things you can measure in the office are sleep, feeding. The majority of pediatricians will not look at things like heart rate variability, any of that. And quite frankly, our we look at heart rate variability in infants, but intra within individual, because we really don't have normative clinical metrics for what is a good heart rate variability and what is a not so good. We generally know that less heart rate variability is not good. More heart rate variability is good. And all that means is that the heart responds and adjusts to environment. But pediatricians aren't regularly going to pay attention to that. That's much more of a research tool. I don't, did that answer the question? Do you want me to go into more detail?
I think that was great. Juan, let us know if you have any follow-ups.
Sure.
Um, Lisbeth asks, does the structure of the American healthcare system impact how you see your role in healing your patients, either positively or negatively? And is there a way that you can measure your impact in your various roles?
Yeah, so two good questions. So yes, the structure of the American healthcare system does impact. Not just for me, but I think for many healthcare professionals, it does impact the capacity for as a healer. And I mentioned earlier that healthcare is a privilege, but it's also a business, or maybe I should say, and it's also a business. And healthcare has become much more. In America, our healthcare system is very expensive, and it has become much more profit driven, or at least focus on how to make it financially sustainable. And so there are a lot of changes in the healthcare system that many physicians will say, or generally not just physicians, but healthcare professionals will say, get in the way of their ability to actually care for patients. So some of those are the need, for example, to get pre-authorization of interventions or tests that you may want to do, pre-authorizations from insurance companies, and they may often be denied. If you work as part of a large group, there will be metrics of productivity. That is how much time or how many patients to see to generate a given kind of productivity, a kind of benchmark. Those are just some of the aspects of medicine as a business. So to put it in realer terms, a physician might be with a patient who has brings up a problem that is not in their problem list that they've been seeing for a while, an unexpected complication or need, and a physician that is having to meet a certain quota, if you will, and may feel deeply constrained on the amount of time that they can spend with that patient, but that patient really needs the time. Now, most physicians, being who they are, being why they went into medicine, will spend the time and figure out how to make it up somewhere else. But that creates a kind of stress. It creates a kind of stress. And having to negotiate with payers, negotiate around pre-authorization, negotiate how many patients to see can get in the way. It doesn't always, but can get in the way of your identity as a healer. That is, as a healer, wanting to do whatever you think your patient needs to get better. Is there an easy fix in our healthcare system? No, there's not an easy fix. Many people are calling out for universal health care, for single payer. All of those things are potential, I would say not quick fixes and not easy fixes, but we have an overburdened, expensive healthcare system that does not reach all people. And we have large swaths of people in our country that are not getting the health care they need, even though we have also the most probably advanced, technologically advanced, research-driven healthcare system in the world. We also have a very expensive healthcare system that doesn't work for everybody. I realize, a slightly more darker, pessimistic picture. But that is the way. I think that is something that we certainly can change and should continue to try to change. But that does get in the way of being a healer.
Thank you for sharing that.
Sure.
Juan asks in the chat, do you conceptualize early childhood dysregulation primarily as a disorder of stress physiology, reward circuitry, or autonomic imbalance? And how does that framing change pediatric intervention strategies?
You're asking great questions, Juan. And what I would say is I conceptualize all three of them. I don't say that I think those three areas are actually overlapping. And again, pediatricians aren't thinking in that way. You're thinking like a wonderful developmental physiologist or developmental neuroscientist. Pediatricians are not typically thinking about in those particular ways. They may think about a child that has a sleep problem, and then they're going to think very practically. They're going to get a sense of that child's what's called sleep hygiene, the sleep practices, but they are not thinking about necessarily autonomic regulation or any of that. They're thinking more end outcome. As a researcher, I would measure all the things that you've raised the question about. As a pediatrician, I wouldn't be doing that. I wouldn't be having electrodes, uh, uh, biophysiological measures of the child. So the question you're asking is great. It's really great. It's a great research question, not necessarily. And there would be, I suppose, another way to put it is that uh, and this is something we need to change. But the translation of research findings to actual practice is a very long process, sometimes longer than 10 years. It shouldn't be that long, but the translation it takes a long time. And so I would love to have a number of the things that we study about stress regulation, autonomic regulation, translate more quickly into practice, but typically it takes a while.
Another question asks from Ramisa, what was an experience that made you want to change or question your profession, if any?
I appreciate the question. I don't think I've had I don't think I've had an experience that actually makes me question my choice as a physician or a pediatrician. But I do think uh, you may have sensed it in my answer just a moment ago. I do worry about the change or the increasing pressures in medicine as a business. And I don't mean to make it sound like a business is a bad thing, but I do think there's ways that medicine, the practice of medicine as healing, is not completely compatible with the practice of medicine as a financially driven business. And I think there's just certain ways they're not compatible. They're different languages. They are not the same as um, having a successful factory or designing, perfect cars, or it's not the same caring for people, though we often bring some of those principles of productivity and business management into medicine. It doesn't make me question my choice of a physician as a physician, but it does make me wonder, worry for what medicine, again, broadly, healthcare profession will be facing in the next decade, 2 decades. I would still be a physician now, even as medicine is changing. I would still be a physician now by what I said earlier, that I feel like it's a gift, it's an honor. But I do think there are different challenges now.
Lisanne asks, how long did it take for you to become a pediatrician? On the way, did you ever feel unmotivated and want to quit?
Um, let's see. I can answer the year question. 4 years of medical school, 3 years of pediatric residency. So that's seven, plus 4 years of college. But so 7 years to be a pediatrician. Then I added 2 years of fellowship in neonatology and 2 years of fellowship in research. But you don't have to do those last 4 years that I just listed. It's really 3 year residency to be a general pediatrician. If you then want to be a specialist, it's usually another 2 years. So 4 years medical school, 3 years to general pediatrician, then usually 2 to 3 year specialty training. No, I never wanted to quit. The only, I even wouldn't call this a quitting moment. This was more of a reflective moment between my first year and second year of medical school, because I think I said earlier that having come from a liberal arts education, um, and I was I was a chemistry major in college, but I deeply, deeply still do loved history, and I wanted to see if there was a way to combine the two. So I don't know that this was quitting, but I did go to graduate school in history, or started graduate school in history between my first and second year of medical school. I just wanted to see what it was like. Um, and at the time, I would say probably I didn't listen to the advice well, but I was told there really weren't a lot of jobs for historians. And I went back to the second year of medical school. But it wasn't really a quitting moment. It was a probably too fancy a word, but it was a discernment moment. I wanted to be sure. Was this really, really it? And I went back to medical school.
Wow, that sounds like a big life crossroads that you were at there.
And kind of, yeah, kind of.
But Deer asks, and a couple other folks seconded his question, what is a case or patient that you've worked on that was interesting that you still ponder to this day?
Oh, I love that question. I have many. But I think here's one that I actually recently wrote about in a different setting. So when I was, this was not, this goes back a while, but when I was in the neonatal intensive care unit, um, at that time, infants born around 400 grams was a very, very, very small infant. And the mortality rate was extraordinarily high for that weight. Was a baby born, I believe she weighed 420, somewhere in that range, grams. Very small. And her mom had had a very, very difficult pregnancy. And so it wasn't entirely clear if she was really born at around 24 weeks gestation or maybe she was a little bit older, but still, but not, but with such a stressed pregnancy, what we call small for dates, wasn't really clear. But she was the smallest baby in the nursery at that time. She was actually the smallest infant. And no one really thought she would survive, but she did. And she had all the complications of prematurity, except she didn't have the lung problems. She didn't have the uh, lung disease of prematurity, but she had many others. But every one of them, she made it. And she became the kind of, when you talk about relationships, um, she really somehow pulled for everybody in the nursery to come by, and they would stop at her isolette and they would talk to her. And without revealing, I mean, her last name, well, I'll simply say, uh, we gave her the nickname of Lunchbox because she was small enough to fit in a lunchbox, a small lunchbox. And it was also a bit of a play on her last name. And her mom, not because of not wanting to, but just could not get into the nursery very often to see her. And um, so she really was adopted by the nursery. And being so small, she stayed there for a long, long time. And I often think about her now that I know so much more about stress maturation of systems. I realized that what her saving grace was that she was probably extraordinarily stressed in utero, which had led to a hypermaturation of systems as she was born. And she had some quality, even as a 420-gram infant, that pulled people to her. People gave her all sorts of attributes that she was a fighter, she was this, and she was that. And so, where all this is leading is that I then had rotated off the nursery and I was out of the nursery when she was discharged home. And she was discharged to home. I didn't see it happen. Um, and I have often gone back in my mind because she would now be maybe a mother, maybe a grandmother, but she would certainly be a mother herself. And I've often wondered what happened to her. No surprise, given that I think about development over time and outcomes over time. But she sticks in my mind, um, mainly because, well, she sticks in my mind for many, many reasons, but partly that almost ineffable quality of from the very moment she entered that nursery, people wanted to take care of her. And there was a quality there, an interaction there that I think we don't take into account so much. So that's one example. I have many, but that's one.
Wow, thank you for sharing that story with us. I
Sure.
think we have time for a couple more questions. Sorry, folks, I know there are a few things that we didn't quite get to, but I see one here from Kirtika saying that they are hoping to go into health policy after medicine. Is there any work that you would suggest doing between undergrad and medical school to work towards that?
Oh, yeah. No, thank you for going into health policy. Uh, we need more thoughtful people in health policy. So I think the more you can get exposed to organized healthcare, to the academic health system, but to healthcare companies, hospital management organizations, the more you can learn about that, and the more you can also learn comparative policy. That is, how does healthcare work better in other places? Does it? Does universal healthcare, uh, such as in the UK or Canada, What are the strengths of that? What are the weaknesses of that? The more you can immerse yourself in those kinds of questions and really, really be exposed to it from an economic perspective, from a historical perspective, from a practitioner perspective, and from a patient perspective, better. Because these are complex, complex questions. Everybody thinks we have a simple fix, but it's not simple. And we really do need people in health policy that will think about it from a patient's point of view, as well as from a sustainable systems point of view.
And our final question, I see something that I don't think we've touched on yet. Veronique asked, would it be possible for someone who is not a Yale student to get involved in research at the Child Study Center? If so, what is the best way to find or pursue those opportunities?
Yeah, no, thank you for that question. We have a summer internship every summer, and we do have actually we have students who are not at Yale with us every summer. Unfortunately, for this summer, the application deadline is already passed, but we do have something on our website. I think it's called the Developmental Something Summer Internship. There also are other internships, though, at Yale for students coming from around the country, even the world. Because our idea is that it's not just for Yale students. That we want to help people think about healthcare. So if you want, I'm fine to get an email from you. I'd be fine, and I could direct you to various places.
Thank you.
Thank you so much for offering that. And if you'd like that email, be sure to send us an email at info@prehealthshadowing.com, and we'll be
Great.
sure to share that.
Thank you.
Thank you so much, Dr. Mays, for
Pleasure.
all your insights. We're going to jump into our wrap-up slides. Right, here we go. All right. So now would be a great time for us to reflect, for you to take some time after the session. I know Dr. Mays talked about one of her reflective moments, so we hope you have one of those while you're thinking through these questions. Or if you find that anything has popped up in your mind, feel free to send us an email so we can try to get those questions answered for you. And also, we'd love to see your insights on LinkedIn. So if you'd like to expand your professional network, be sure to follow us on LinkedIn and share any of your reflective moments. We'd love to publish them, share them with the professional network. It's also a great place to see if you're interested in anything new, any internships or job opportunities. LinkedIn is a great place to get connected to some of the organizations and people that we work with. Again, if you're interested in becoming a part of pre-health shadowing, please check out our website. Again, all of our positions are 100% remote, so you can do them from anywhere. And the time commitment is relatively variable. So if you have more time some weeks or less time, we are super happy to work with folks. We know we have a lot of students in our organization, and we want to help you further your education as well as your time in pre-health shadowing. Again, if you can donate either financially or your time or sharing any of our links with your network, we greatly appreciate it. We run solely off of the time and donations of you all and our volunteers. So excited for that opportunity. Please, please share if you can. And we also have our post shadowing assessment. So we do have a 10-question quiz that is currently up on our website. It is multiple choice. You're going to navigate it through the same place that you went to get access to this course. And after you complete it, you will get your certificate digitally immediately after. So let us know if you have any questions surrounding that. And if at any time you missed any part of this session or any others, feel free to check on our YouTube channel where this will be updated. Dr. Mays, if you want to send this to your network, if they want to see you on the big screen, we'll send you that link as well. And you'll live in our YouTube family forever. So we're so appreciative of your time, and your energy and your presence and answering so many detailed questions, so many specific ones too. It's really invaluable for our team. So we're so grateful. And for all of you watching, please be sure to catch our sessions every week. Our next session will be tomorrow at 5 p.m. Pacific Standard Time. So we'd love to see you there to chat with our next health professional. Thank you all so much for coming. If you have any questions, please stick around um, for our team, and we can answer any of those. Dr. Mays, thank you again so much. We appreciate you.
Thank you. Sure. Thank you. Bye.